you know, everybody knows he's the one of the expert intervention cardiologists in Bangladesh. He's fond of coronary intervention, but he always boosts peripheral intervention and congenital heart disease because peripheral intervention and congenital heart disease is neglected in Bangladesh. He always promoted as a director of NICPD, always promoted in NICPD peripheral vascular disease, also PTMC, valvular valvuloplasty, always promoted these subjects. So in BIT, today's program for the more interest for the junior fellows for interest in the vascular medicine. We are really grateful, Dr. John. He is the expert in this field. I welcome John. Today's panelist expert, I introduce Dr. Kaisan Nasrullah Khan. He is the senior consultant of United Hospital. He also coronary people, but also doing the peripheral. Dr. Tamjid is coronary, but he's doing peripheral. Two vascular surgeon and Habibur Rahman. He's a National Heart Foundation. He also coronary doing peripheral, but two vascular surgeon here. Dr. Jia Mokbul Hossain, he is the most expert peripheral intervention in Bangladesh, and Dr. Abul Hassan Mohammad Bashar. Welcome everybody to today's session. Today's first lecture, you know everybody, given by the Dr. Jon C George. His talk on peripheral vascular intervention for chief operator. Dr. John, would you please start your talk today? Thank you, John.
Thank you, Dr. Ahmed, Dr. Rahman, and all the esteemed panelists and BIT for inviting me to give this talk. And it's an honor really to be able to share my experience and also hear from all of you as experts in the field about complex peripheral interventions. Can you see my slides?
Yes, yes.
Okay, so the topic for today is peripheral interventions for the CHIP operator. I was honored to be there at BIT in February, and we all know things have changed since then with COVID and how it's affected the entire world. But I'm glad that we're having a format such as this to be able to continue our education and talk about important topics. So looking at a CHIP operator, one of the first definitions that we have to define is what is a CHIP operator, and CHIP is defined as complex higher risk indicated patients. So an operator that does interventions in these patients is a CHIP operator. And speaking of peripheral interventions, a lot of people on the panel and a lot of people in the audience listening to this are coronary interventionalists, and so we'll start with coronary and kind of switch over to peripheral interventions. But there's a myth out there that CTOs are predictable. CTOs are chronic total occlusions, and that interventions of these occlusions are predictable. And I'll show you a case that demonstrates how it's not predictable. So this was a patient that came in with a right coronary chronic total occlusion. And in the evaluation of patients with chronic total occlusions, when you see a vessel that's lined with stents and it's occluded, the tendency is to think that this is going to be a chip shot case, that this is going to be very quick. It's easy to cross through stents, even if it's a chronic occlusion. And that is not always the case. And what you see here is our traditional setup for a CTO intervention with dual access, both coronaries engaged. We're shooting the left system, which gives collaterals to the right, shooting the right, and you have antegrade wire access and trying to cross this lesion. And what you see is that we've hit a roadblock here in the mid-RCA, difficult to cross that mid-segment of the stent. And when you see it in an oblique view, what you notice is that the crossing catheter is slipping outside the stent and externalizing because it's so fibrotic and within the occluded stent that the wire, the easiest pathway for the catheter and wire to cross is outside the stent. Obviously, that is an option. You could continue to traverse that way and crush the stents if you can re-enter into the true lumen distally. But of course, that's not ideal because you'll end up crushing a lot of metal on one side of the vessel. So instead, we decided to come retrograde at this point. And so we've gone through LAD septals coming retrograde into the distal right, and we see that the same issue is happening again, where the catheter and wire are going outside. Here you'll see the wire traversing pretty nicely retrograde all the way to the proximal segment. But if I show you a close-up, what you see is that this segment of the crossing has been outside the stent. You see that the wire has crossed outside. And again, you have the same option of just crushing the stent here, since you're true lumen there and true lumen here. You have the option of crushing the stent, but it's not ideal. So you'll see that eventually, after a lot of manipulation and using specialty wires, we were able to maintain true lumen retrograde and subsequently complete the crossing true lumen back into the guide where the wire is externalized, and the entire CTO completed with an excellent result following laser atherectomy, angioplasty, IVUS imaging, and repeat stenting. Now, why did I present that case? Again, just to demonstrate that CTOs, although people say can be predictable or they could be chip shots, even when they are in stent, they're not necessarily predictable. And the reality, again, is you don't know what you're going to get till you're actually in the case doing the procedure and recognizing that you have wiring issues. So let's switch gears now to peripheral interventions. So when should you be concerned in doing peripheral interventions or even coronary interventions? Once you have multiple risk factors, elderly patients, age greater than 70, women in particular are higher risk, especially as they get older, obese patients, any presence of a known peripheral arterial disease, patients with decompensated heart failure, decreased pulmonary reserve or COPD, patients with renal failure, thrombocytopenia or coagulation issues. All of those are high-risk patients for developing a complication during a coronary procedure or a peripheral procedure. So looking at predictors of 30-day mortality, we have data on this that suggests that as you accumulate these risk factors, and if you have any sort of perforation or a long complicated case with fluoroscopy time that's gone up, the cumulative mortality rate goes up. So the reason why I present these slides is to, again, impress on you the importance of being a chip operator that is able to do some peripheral interventions as well, because these are the patients that develop risk. And so if you see access-related complications, this is a patient that had a obvious retroperitoneal bleed that is visible here with the large bore sheath access. And you need to be able to take care of this immediately, or the patient decompensates. And if it is a patient that has multiple comorbidities, including heart failure, and they decompensate pretty quickly and they circle the drain. And so this needs to be treated right away when it's witnessed. And it's simply treated with just a covered stent and quickly gaining access, taking control of that situation, and the problem is resolved. And so that is a simple issue. Other issues, this is a patient 1 hour after treating an acute ST elevation MI. This was a 46-year-old woman with diabetes and hypertension. Had a stent to the proximal LAD. Access was the left groin, and closure device was placed at the conclusion of the case. And then just within an hour post-procedure, the patient developed a painful and cold left leg. And so the patient was brought back to the cath lab, and this was an angiogram done from the right lower extremity up and over. And you see that there's a complete occlusion in the common femoral artery at the site of the access from the closure device. So this too is a relatively common occurrence and can happen with closure devices. And you need to be able to treat that immediately if you're a chip operator. And again, try to cross it antegrade. If that doesn't work, come retrograde. But it can be crossed, and so you see that there's still some clot that needs to be addressed. And prolonged balloon inflation and a short focal stent at the site of the issue, and the complete issue has been resolved here, and the patient flow has been restored. What about radial access? I think a lot of the operators, chip operators, are now utilizing radial access for multiple procedures. And this is a young patient, 40-year-old, but multiple risk factors, including diabetes, is a smoker, multiple high-risk complex PCIs that this patient has had from radial access, because we know that the risk of bleeding is definitely lower from a radial access compared to femoral access. But unfortunately, after multiple PCIs, this patient's radial artery occluded, which is okay as long as the ulnar access is preserved or ulnar flow is preserved. But this patient pre-CABG had an ulnar access for a diagnostic procedure, and unfortunately 3 days later presented with a cool and painful hand this time. So now you've occluded the radial, ulnar access was used for a diagnostic procedure, and now the ulnar is occluded as well. And this was the diagnostic image that was taken with minimal flow to that right arm. And again, this is something that can be quickly treated. What you see is that flow is restored. This is a nice demonstration taking the radial loop in the wrist and going right back up. And you have a good, when this wire is retrieved using the same retrograde techniques like doing a coronary CTO, you now have complete access of the arterial flow into the arm through the radial and ulnar arteries, and you can angioplasty that and get a great result. And that patient did very well after resuming flow. What else do you encounter? Lack of available access sites. You see these patients that have advanced peripheral vascular disease, where bilateral iliac arteries are occluded, and you have a distal aortic occlusion because of a Leriche syndrome or advanced atherosclerotic disease, and concomitant heart disease that requires a coronary intervention with possibly hemodynamic support, and you don't have enough access for large bore entry. We've gotten very proficient at doing large bore access, even from brachial or axillary. Those options are there, but sometimes, as in this case, as a patient with chronic kidney disease as well, with fistulas in the upper extremities that prevented upper extremities as well. So instead, we did something here where we revascularized the lower extremities percutaneously in order to provide access to be able to do the coronary intervention. And so what you see here is access from both femoral arteries, wire crossing from the left femoral artery, true lumen in the aorta. However, from the right common femoral artery was subintimal crossing. And you'll see that this catheter, this wire and catheter are in the subintimal space. We brought a re-entry catheter. This is a Pioneer catheter with IVUS guidance that allows you to see where your subintimal plane is in relation to the true lumen. And the red color that you see is the true lumen. The catheter is in the false lumen and the subintimal plane. And you're able to direct that re-entry catheter to enter the true lumen, balloon, and stent into both common iliac arteries to get a great result now and reestablish flow into both lower extremities, which now gives you 2 access points. And these are large stents, about 14 millimeters, that allows you now to take anything from the femoral access to do a complex procedure in the coronaries. And, the availability of doing coronary interventions and doing complex coronary interventions allows you to then take the skills that you develop in the coronary, complex coronary interventions, especially in CTOs and CHIP cases, into the peripheral world, because the strategies in the peripheral in endovascular interventions is just catching on to what we've developed in coronary interventions from a percutaneous standpoint. So here's something that you'll see that is a very complex case. What you see is an injection of the celiac artery. And unfortunately, this is not looped, but if I play this over and over again, that is filling of the celiac artery. And what you'll see is that you have collaterals from the celiac artery supplying the superior mesenteric artery. So this is the flow to the mesentery from the celiac and the superior mesenteric. And this patient had severe malnutrition and abdominal pain and mesenteric ischemia because both his celiac artery and his superior mesenteric artery were occluded. And he had his his celiac artery stented, and that's what you see here. There's a stent in the proximal celiac artery, but he continued to have symptoms because his flow into his superior mesenteric was still through collaterals. So at this point, the decision was made to intervene on the superior mesenteric, but you'll see that it's not as easy. There's the stump of the superior mesenteric artery. Right there, you see a little nub right under the celiac artery stent. You'll see reconstitution of the artery. The reconstitution of the SMA is a little bit further down. So we tried, of course, antegrade first. What you see here is a wire going through the occlusion, but entered a subintimal plane and has not entered the true lumen here. Even though this is a huge target of reconstituted vessel, you have a looped wire in the subintimal plane right outside the reconstituted segment. So what do? We used our re-entry techniques that we use in the coronary space. This is a Stingray catheter that we use for re-entry over an 014 wire. It's an eccentric balloon and allows you to direct the wire into the true lumen. And so this is positioned right inside the reconstituted SMA. And then if you watch this video, you'll see how that wire is being poked through the lumen, the outside lumen, and it just pops into and goes down the SMA. So this is a re-entry technique that we use in the coronaries that worked out very well in the mesenteric space with an 014 wire, and the entire SMA was reconstituted and stented with a great result. Now with a stent in the celiac and the SMA, and a great result. And this patient did extremely well, and we published this in CCI journal as a case in the mesenteric. What about when you need to use hemodynamic support and you have extensive peripheral vascular disease? So this is a 74-year-old male patient with ischemic cardiomyopathy. He refused a high-risk intervention 2 years prior. He came in now with a non-ST elevation MI in shock. EF was about 10%, and severe peripheral vascular disease. He had a radial angiogram done, showed severe left mace, a CTO of the circumflex, a CTO of the French coronary guide, access for hemodynamic support. But unfortunately, the left femoral access image that you see here demonstrates that you have, an occlusion in the common femoral and SFA with reconstitution and severe disease in the distal common femoral and external iliac arteries. So putting a large bore hemodynamic support sheath here now occludes the flow into the limb completely. So the entire procedure was done with Impella support, But it was important to maintain limb perfusion while the patient was weaned off of the support device. And so an easy way to do that for a chip operator is to get antegrade access into the reconstituted vessel. So in this case, we got antegrade access in the popliteal artery. And then you do a male-to-male adapter from the common femoral artery into the popliteal artery. And because there's no flow, there's a gradient that allows automatic flow into the popliteal artery and perfuses the limb. This is a different patient doing the same sort of limb perfusion, but it demonstrates how that works. And so this is the impella sheath. And as soon as you open, this is an antegrade sheath, and it allows blood to go from the side port of your occlusive impella sheath down into the antegrade sheath, and then perfuses the limb so you don't have limb ischemia while you do these complex procedures. Having said that, I'll tell you that now we've gotten facile at being able to do high-risk, large bore with a single access, where you use an impella through a 14 French sheath and direct a guide through the exact same to be able to do the intervention if you have at least one access. But if you don't, then this is an option to perfuse the limb. Again, that's the video demonstrating how the flow goes down the limb. And finally, I just, if you're intimidated by peripheral interventions, I would like to point you to a study that I'm really proud of. We just published this. If you look at the date, it's August 22nd, 2020 in the Journal of Invasive Cardiology. And this was a study that we've been working on for several years. And this looks at femoral popliteal CTOs, so looking at SFA CTOs, and how do we develop a score and an algorithm for someone to be able to learn how to do interventions within that space. And it's called the FACTOR study and a FACTOR score. It's femoral artery chronic total occlusion revascularization. And I'll lead you through that before we open up for some discussion. So some of the considerations that we have for being able to do complex interventions in the peripheral vascular area is to transition rapidly from device, using a device for crossing. Then if that doesn't work, then to quickly switch your mode of operation to be able to perform a wire-based strategy. Implement wire escalation quickly if something's not working, rather than continue to waste contrast and radiation to doing the same thing. Timely alternative access site conversion. So to be able to switch access sites, and if antegrade's not working, to come retrograde and escalate the access sites. Becoming proficient with all CTO devices, whether that be crossing devices, re-entry devices, all the materials that are available with technology currently to be able to make your job easier. And be aware of radiation exposure and contrast use. Those are the things that limit you in these complex interventions. So we developed a FACTOR score. It's a 10-point predictive score for evaluating the complexity of SFA CTOs. And this is similar if you're a coronary interventionalist and you know the JCTO score. This is a similar sort of application of a scoring system for peripheral occlusions, for peripheral CTOs, SFA CTOs particularly. So looking at the morphology of the cap, you assign points based on what it looks like, if it's tapered, blunt, or it's a flush occlusion. You look at the degree of calcification, because greater the calcification, the more complex the occlusion is. Length of occlusion in millimeters. So as the occlusion gets longer, it becomes more complex. The presence of collaterals at the occlusion cap. So if you have no collaterals at the occlusion cap, you can direct your wire probably into the true lumen easier than if there are multiple collaterals at the cap. The wires and devices tend to take those collateral channels. And so that complicates the procedure. So if you have collaterals at both the proximal cap and distal cap, that constitutes a higher risk or more complex patient. and the number of attempts this patient has had at revascularization. So if you add up all of those points based on the clinical presentation, a score of 1 to 3 is considered a mild complexity or a pretty straightforward CTO. Score 4 to 6 is moderate complexity, and score 7 to 10 is severe complexity. And we'll talk about why it's important to grade these as far as complexity. And here's an entire algorithm to be able to go through these CTO patients. So kind of like you do a coronary CTO, prepping 2 access sites and being able to go antegrade and retrograde in every case, you prep the entire leg of the patient and have ultrasound ready. Be prepared to go antegrade and retrograde in all of these cases. And if your antegrade works, then you bypass all of these algorithmic steps and you complete your intervention. But if your antegrade doesn't work, then you got to think quickly and switch your strategy. If you are subintimal and you're right next to the true lumen, use a reentry device. If that doesn't work, get retrograde access. If that doesn't work, from retrograde access, there's a variety of techniques that you can use with CART and reverse CART and Safari techniques, which are all techniques that are described both in the coronary literature and in the peripheral literature. Then you have the option of going direct SFA access with fluoroscopic guidance or with ultrasound. And then you have a combination of triple access sites with antegrade, retrograde, and direct access to be able to complete the procedure. And from our experience, we've validated this study in hundreds of patients. And I'll tell you that once you have proficiency in all 3 access options, you're virtually almost 90% successful in all CTOs. So here's a validation of the factor score. So if you look at the success rates, you'll see that as you get proficient, the success rate approaches almost 100% if you're able to master all of these access options based on the factor score. And then if you classify them by factor score, you'll see that you'll have a very high success rate with just antegrade access. But if you have intermediate factor score, so increasing the complexity of the case, you start to use more of the retrograde access options. And then if you have an even higher factor score, you'll probably utilize more of even the direct SFA access. And so you'll utilize all 3 access options. And so here's a prescription essentially to be able to figure out what kind of access you need to be able to do in a particular case if you know what the score or factor score of that lesion is for. Again, no need successful initially. What we also found is that experience adds to your success rate. So if you look at the success rate in years 1 to 2, utilizing early on, you may 3 to 4, you're at very close to 100% success rate in revascularizing these SFA CTOs using the factor algorithm. So with that, I'll stop. I'll end with this quote. As you do more interventions and get into the more complex interventions, you will have the absence of complications is a measure of the scarcity of operations. So if you haven't had any complications, that just means you haven't done enough procedures, because you will, even at the best hands, have complications. The important thing is to learn how to get out of them and adequately treat the patient when that happens. So with that, I will stop and happy to answer any questions or discuss cases with the rest of you.
Thank you. Excellent presentation and talk. After Rohan, sir?
This is a very brilliant talk, I would say that. And the first one that, if you put the first one is the coronary, that's right. Your wire is outside the lumen. It is outside the stent. But does it is outside the vessel? No, not really. And you say that you can compress the stent by another stent. But what happened? What is the fate could be happen at the time? Suppose
so if we weren't able to cross through the true lumen
That's
and
fine.
we had crushed the stents, that's fine, as long as you maintain true lumen to true lumen patency. So you just have to make sure that the final stents that you employ are adequately expanded and the old stents are adequately crushed. But that complicates the procedure because, those are sites, because of a lot of metal compressed on one side, you would probably develop restenosis. So it's not ideal, but it would open up the artery. And we've done those cases where you're not able to cross in the true lumen. Part of the reason why when we IVUS this at the end, we realized why the vessel, the wire and catheter were going outside is because those stents were significantly underexpanded. They were not adequately expanded within the vessel by IVUS. And so if you don't expand it well, you have a lot of room outside of the stent to be able to traverse around the stent. So it doesn't cause any damage other than the fact that the outcomes of those cases are not as good as being in the true lumen.
So another question is that which did you use to go through the true lumen? How did you know that it is true lumen? What are the technique you have adapted?
So we just redirected the wire. Okay. So we ended up escalating the wire with CTO wires. I can't remember which wires we used, but we went through a variety of different wires. I think, typically we use a hydrophilic looped wire technique. And so we had to take a weighted Pro 12. I don't remember. The Stato.
You closes the femoral artery by just the wire. Why it is happened?
So it can happen. Collagen, if it doesn't come all the way up to the arteriotomy, then the collagen goes inside the vessel. And so you in a diseased vessel inside the artery, and if it doesn't come all the way up to the arteriotomy, then you end up deploying some of that collagen into the vessel and then it clots up. That could be a reason. In a suture-based technique like Perclose, if you don't, again, same sort of scenario, if you don't bring the suture back up to the arteriotomy, or you catch a back wall of the artery, you can actually suture the whole vessel shut, which becomes extremely difficult to reopen. You can reopen, you can break those sutures and reopen it percutaneously, but sometimes those need to be treated surgically as well, because you can suture those vessels shut, and those are tough ones to open up.
Is it possible to tackle the situation only by balloon angioplasty? No.
You can look at the result after your prolonged balloon angioplasty and then take a look. But if it looks bad, or if there's significant clot, or there's mechanical obstruction of that area, then you probably need to relieve it either with a cut down and a surgical endarterectomy, or some sort of percutaneous revascularization, because otherwise the patient will probably clot off again. So it all depends on what your result is. We've left some with just atherectomy and balloon angioplasty, and others that we had to stent.
Thank you, Dr. G.
Can I ask a question, Dr. John? You have shown a case of juxta-renal ilia occlusion. What was the stent size you used in this kissing stent?
So what I ended up using was a 20 millimeter wall stent in the aorta. So I used a single stent. It's called a CRAB technique, and I don't have the time to go into that right now, but it's a single stent in the aorta. That's a large stent, and then two 14-millimeter stents into the large stent. So you basically have one large stent and then two bifurcating trunks come into the iliac arteries.
But aorta is a very big vessel. There is huge burden of thrombus. Was there any chance of thromboembolism in sort of cases?
Very little. There is a risk, but I'll tell you that a lot of these are fibrotic and completely occluded. So this is not like fresh occlusions. They've been occluded for years, and part of it is subintimal crossings. So you're not even necessarily utilizing all of the true lumen space. So the likelihood of embolization from that is extremely low. What you do have to be worried about is perforation. If you do have, you have to be familiar with covered stents and balloon occlusion if you do have a perforation. But other than that, embolization is pretty low.
Thank you.
Mm-hmm.
Thank you.
Thank you, Dr. Jon, and Dr. Mohsen as well. It's an excellent presentation. Actually, I want to confine to peripheral procedures. As you said that you have devised, like JCTO, you have device factor scoring. This is excellent. I believe we have some subgroups of the JCTO like scoring, like A, B, C, D, different. So it helps to open up the normal artery. Normally, what we normally find from our clinical experience, of course, we haven't done as like you, but we do the SFS. CTO is much easier than the coronary CTOs because it's a straight line, and and chances, mortality risk as well much less. You can go with the microcatheter and cross the lesions. It helps, but as you said, you should have two approaches, either antegrade or retrograde. Now, for the purpose, for the SFA purposes, so far we have done only the antegrade approaches for CTO, but retrograde, like puncturing the popliteal artery, how is it possible on supine position? Is it possible we have to move the patient semi-prone, do the two sides, from antegrade and retrograde, open up the SFA?
Yeah, that's a great question. So we used to go prone when we got popliteal access, and as you can imagine, it gets extremely cumbersome because you'll have to flip the patient and re-prep the prone position. Then you need access to the common femoral, and so you need to flip the patient back, and it gets very cumbersome. So now we don't even go. Everything is done in supine position. It's a frog leg position for the leg, and then using ultrasound get popliteal access if you need popliteal. But I'll tell you that majority of our retrograde access is not even popliteal. We go pedal. So just like radial access has become extremely popular for coronary interventions, there's a big push to go into pedal access for peripheral interventions. The problem is that our catheters and devices haven't caught up to small caliber sheet sizes, but it's getting there. So we go retrograde for crossing, and then we treat antegrade. And so you can get pedal access with ultrasound, you can get AT access, perineal access, posterior tibial artery access, and cross retrograde, externalize the wire, and then deliver all the treatment from the contralateral access. And so I don't even use popliteal very much anymore, but when we do use it, we go frog leg. So frog leg is just bending the leg and then rotating it externally a little bit on the table. And so you can visualize the popliteal fossa. But you still need ultrasound to be able to do that. And so we utilize ultrasound in 100% of those cases.
Thank you. But the parallaxes, which sheet are commonly used in your working sheet in your lab for the parallaxes?
So for the pedal access, we're using the same that we use for, so Cook makes a 2.3 French micropuncture pedal sheath, and that's what we typically use. And then you upsize if you need it. So if you need to upsize, so that'll allow you to take a crossing catheter, an 018 crossing catheter and an 018 wire retrograde with that 2.3 French sheath. If that if you need to upsize it for devices or anything like that, then we'll use the same radial sheets that we use in your radial arteries for coronary interventions.
Thank you. Dr. Kaisen Rasulullah Khan. Dr. Kaisen Rasulullah Khan.
Yes, sir.
Yeah.
Hi.
Excellent, George. It's one presentation. I learned a lot. I believe that in Bangladesh, the peripheral cases are still, especially diabetic food, because of we don't spread our peripheral intervention. And there's lots of patients. I think if we can develop this sector, then we can help many patients. So and we can help the patient not to get amputated. So this is a common problem here, especially diabetic legs. And about other sites of peripheral intervention, especially the AAAs and the dissection of the aortas, carotids, and you have shown a case of mesenteric ischemia. Though they are rare, and they need a good source of economic resources as well. But the food we can do easily, because most of the things below we can do with ballooning as well. Yep. So I think this your lecture will help us to go ahead, and thank you so much. Just a small question: that doing stenting in bends like knee bends, hip joint, which stent do you prefer? The Boston one?
So in the joints, supera stents, which are interwoven nitinol stents that has the greatest radial strength. So there's no fracture rate, 0% fracture rate for supera stents. And they're extremely flexible, and the radial strength is the greatest of all the commercially available stents. So that's what I use specifically in the common femoral or popliteal joints if I have to use a stent. But preferably, you try to avoid using a stent in those areas. But if you have to use it, that's what we go with.
What precaution should use the supera? What precaution is the more flexible, and is the length is how you manage the supera in the flexible joints? Any tips for ours?
Yeah, so it requires, as you know, it's a complicated delivery system. It's a ratchet driving system where you can actually modify the length of the stent deployed. We actually published a paper on the outcomes based on how you pack those stents. So if you pack them in tight, then the outcomes are much better than if you elongate the stent. So if the stent starts elongating and you're not able to pack it in, then your results will be terrible over the long term. The restenosis rate is pretty high. So part of being able to use the supera stent is also to develop an expertise in being able to deploy them appropriately. And the most important tip that I can give you is to prep that vessel properly. So if it's calcified or if it is underexpanded, then you will not be able to deploy the stent appropriately. So you need to make sure that you're able to balloon 1-to-1 or maybe even a little greater than 1-to-1, and then deploy the supera stent and pack it in as best as you can.
Dr. Habib Rahman? Dr. Mabul,
I like to add something. As Dr. Nasrullah Khan is telling, use a lot of patients in Bangladesh, definitely. Every person is a single heart, but every person has got 2 upper limbs, 2 lower limbs, as well as the thoracic aorta, abdominal aorta, and so many branches. So there are limited coronaries, but head to toe, there are a lot of arteries and lot of interventions are there. But problem is the peripheral lesions are mostly CTOs, as well as it is long lesion. So more and more time, more and more devotion is needed to cross the lesion, number one. Number 2 things, if we have got no covered stent or coil or glue, the emergency things in hand, then we will feel problem, and this is a disaster, and at the cost of limb or life, anything may happen. Another thing, the peripheral patients has got ulcer, gangrene, or foul spilling, etc., etc. But coronary patients, yes, patient is okay, fine, there is no foul spilling, etc. But the peripheral patients, sometimes it is very difficult. Even the operator doctor to face the patient as the patient has foul spilling, gangrene, so we need that is multi-speciality take care, that is wound care, that is amputation. So comprehensive vascular care is needed for peripheral intervention. And in this text, we can utter the word the hybrid cath lab. Why hybrid cath lab? Suppose there is a lesion in iliac, we can easily cross the lesion, stent. But there is a situation we have failed, and we can bypass the lesion in the same sitting. Or any sort of complication happens, if we fail to solve the problem with the endovascular technique, we can open the problem. As well as in the same sitting, we can take care of the wound, as well as we can amputate the affected part. So hybrid cath lab concept is very much essential for the peripheral cases. Thank you.
Yeah, I totally agree. I think that's a very important point. I think, you need multiple specialties to be able to, in the end, you're taking care of the patient, not just the disease. And so as much as the revascularization works, you still are left in critical limb ischemia with the non-healing wounds or infected wounds that still need long-term wound care, skin grafts, even if it is revascularized appropriately. And partial amputations, hopefully limited amputations, but limited to toes or metatarsal or below knee amputations. But you want to try to save as much of the foot as possible, and that's only possible with collaborating with multiple specialties.
I want to add something, Mukbul.
Yeah.
Most important thing is that we have a less number of the people, and we have less number of the dedicated people like you. Some of the cardiologists doing the peripheral in addition to coronary, but their primary job is the coronary. Because I must say that I have discussed with Mohsin. Then Mohsin will start independently peripheral in the cardiology department. But unfortunately, due to shortage of my time, I could not start that. Hopefully, he will start that in cardiology. The other thing is that we have a big plan for the, NICU has a big plan for the cath lab in the OT. You can remember that you were the people here, Mukbul was there and Bashar was there. You have built up the beautiful 3-operation theater in the NICBD. And this is well designed, well planned. Hopefully, you will very soon you will start that. Can start that. If the activity started, then you will start. But we have to increase the number of the people. And we need dedicated, mainly dedicated to peripheral, not dedicated to coronary. We need more people dedicated to peripheral. Then he can do the coronary in side by side. You can think about that NICBD. The EP, before doing the independent or electrophysiology department, there is a less number of the EP. Now it is EP is independent, Mohsin is doing that fine, and Atar is doing that fine, and they are overburdened with the EP, and they are mainly doing the EP. They can do the peripheral in the other, they can do the coronary in the other side. Now, if you want to develop the subject, you need some dedicated people. That's what's important. You are the legacy, Kaisar is a legacy, Mohsin is a legacy, and Tamjid is also, but Habib is also, but definitely we need some more dedicated people, I think so. And that's most important. And the people like Jon is with us. And I am promised to promote the peripheral with my BIT platform, along with the society, along with the other association. I am promised for that. I have to do that because I am not a peripheral person, but when I see that we have to amputate the leg, that's not good for us. And we have a good friend like Jon, definitely he will help us to extend the support. I am now Tamjid. Sorry for interruption.
I think just continuing your part first. In our small private setup, we are doing the similar things actually. We are like heart team. We are involving vascular surgeons, cardiac surgeons who are doing the vascular part, and plastic surgeons. So as Dr. Magul said, one patient what we did few days earlier, the iliac part, they wanted to do the iliac from iliac part by us, and later went for the bypass, the distal part, because it was totally long CTO calcified, they needed a bypass surgery. So it's a more of a hybrid type of approach in this patient. It was pre-condition that, okay, rather going for the big surgery, go to stent this part, upper part, and lower part, go to the surgery. Dr. Jon, I want to ask you one thing. Going to the below knee procedures like intrapopliteal interventions, what is your preferred way of approach. I mean, just a ballooning or do an exam or, uh, cutting things. But normally, what in our practice, we don't have much things available. So we just do the simple ballooning. Sometimes the DCBs were used before. Now we don't get much type of DCBs either, long DCBs. So we're using long balloons for ballooning approaches. Just ballooning the anteriotubular, posterior arteries.
Yeah, so we're very limited in our options for ballooning intervention. So we have a lot of atherectomy devices. So we try to debulk as much of the plaque as possible with some sort of atherectomy device, either orbital atherectomy or directional atherectomy, shaving off the plaque. We even have atherectomy devices where you can visualize the plaque. We have a paper coming out with the Pantheris device, which actually shows you with OCT imaging the inside of the artery, so you can shave off how much plaque you need to shave off, and then do a prolonged balloon angioplasty. As far as stents are concerned, there is the intact stents that have just been, the TAC stents that have just been approved for baloney interventions. And so those are very short stents, bare metal stents. So just to tack up any dissection planes to improve the blood flow.
As a bailout only, yeah?
As a bailout, exactly. Or coronary DES, drug-eluting stents as a bailout as well. So those are our options, but most of them we treat with just atherectomy and balloon angioplasty.
You always practice the IVUS in the lower limb in your cath lab?
Yes. Yeah, so I use IVUS a lot for especially below knee because, the smaller the vessel, the bigger the risk for bad outcomes if the stents or treatment is not appropriately sized. So it's very easy to undersize a lot of these vessels, especially when you get to smaller arteries. And so I tend to IVUS or OCT a lot of those arteries.
Yeah. I would like to thank Professor Abdullah Rahman sir for arranging such an important meeting, and important issues of peripheral vascular.
Everybody, sound please. Please.
Did you hear now?
Nice.
Yeah.
Nice.
So I would like to thank Professor Abdullah Rahman sir for raising the issue of peripheral vascular intervention in Bangladesh. He has much interest than other operators, I would like to say. And revascularization is one part of management of peripheral vascular disease. But lots of issues to be addressed to organize peripheral vascularization. Podiatry is one of the important subjects which is neglected in our country. Also, involving multidisciplinary approach is lacking. So, as we are cardiologists, vascular surgeons, and radiologists also not coming in enthusiastic manner, so we need to organize in a multidisciplinary approach to manage the peripheral vascular disease, because lots of diabetic patients, lots of amputation is going on, being untreated. So we need to think about this, about the multidisciplinary approach. So I would like to ask a question to John, that you are dealing lots of patients, treating lots of patients in cheap manner, and also have shown the algorithm of treating CTOs in peripheral arteries. We can practice now from now on. But in some patients, not some patients, most of the patients having CKD. So how do you deal with that sort of patient? Having creatinine, might need dialysis and also other therapies. So how do you deal with those kinds of patients?
I'm not sure I understood your question. Sorry, can you repeat that?
CKD patient. How do you deal with CKD patient with much raised creatinine?
CKD.
Yeah, so it depends on what level of CKD. So if it is CKD on dialysis, then obviously contrast is not an issue because you can dialyze that out of the system. If it is CKD without being dependent on dialysis, then we have a no contrast intervention. So that's great that you brought that up, because we're just publishing a paper on no contrast complex peripheral interventions utilizing CO2 angiography. I don't know if that's available to you in Bangladesh, but we can use carbon dioxide to visualize under subtraction the peripheral vasculature without then do it with intravascular imaging and CO2 angio utilizing no contrast. So there is no limitation from a CKD standpoint for doing even complex peripheral interventions, especially in the lower extremities. If it's in the aorta, then it's much harder to visualize, but then you deal with ultrasound-based, IVUS-based interventions.
Thank you.
Okay, can we go for the final last talk?
Yeah, thank you, John. We go to the next talk. I thanks and salute to the hospital surgeon. They're doing lots of job in Corona COVID pandemic. So Dr. Bashar will present the vascular care during COVID pandemic.
Nobody suffered from COVID, that's right?
Yeah. Yeah, nobody's.
Some of the vascular surgeons did suffer from COVID, but fortunately they came out fine. Okay, so can everybody hear me?
Yes, nicely.
Okay, thank you very much. Let me see. I need to share my screen, right?
Okay.
Okay.
Dr. Bashar is a vascular surgeon. He's doing in an ICBD. He can work in an ICBD.
Okay. Is that okay?
Yes, beautiful.
Thank you, sir. First of all, I would like to thank our great mentor, Abdul Rahman sir, our former director, who really has been a great support for the vascular surgeons. When he was in NICVD, we got a lot of support from him and still cares about us. Like he said, he wants to promote us from the BIT platform, and it's really heartening to have messages like that. And I would like to thank my friend, Dr. Mohsin, who also has been a great support for us, the vascular surgery team of Bangladesh. He has been also a source of encouragement for all of us. And thanks the BIT platform for inviting me into this. And I'd also, I didn't take that opportunity of commenting on Dr. George's presentation. Just let me just mention that it has been a wonderful thing and very technical, and we have learned really a lot from his presentation. I know I can tell from my standpoint that there is so much to learn from the interventional point of view. So there's just no end of learning when it comes to peripheral intervention. Things are constantly evolving, new technologies are coming, new devices are coming. So it is very important that we keep up with the developments that are going on all over the world. And Dr. George just comes to show us today that there's indeed no end of learning, and we have to keep pace with it. Thank you so much, Dr. George. Well, I want to start with the little good news. We during the COVID-19 pandemic, actually, we worked, of course we did, and we also wanted to let the world know about our efforts. So we, the vascular surgeons at NICVD, we wrote a paper on our endeavor during the COVID-19 pandemic and submitted to an international journal. And also vascular surgery is one of the leading journals in the field of vascular surgery. And just yesterday, I got the notification they have accepted our original article on the title that you can see. So I think this is a good beginning for the vascular surgeons of Bangladesh, that from now on we can target making ourselves or making our efforts visible the World Forum and different platforms at the international level. So this should give us a lot of confidence. These are some, I know Dr. George's presentation has been a very technical one. Mine is very social. I'll not have to go into any technicalities. So that's a great relief for me. So we'll be talking about the social aspects of the COVID-19 pandemic in this country and how it has come to affect the vascular surgeons and the vascular surgery community as a whole, our patient populations and all those. So I think everybody can chip in with the ideas they have in their minds after I get done with my presentation. It's a very difficult time for all of us, isn't it? We haven't really encountered anything like this in our lifetime, so we really don't know how to react to this. So it has not been really easy for any of us. You talk about cardiologists, you talk about surgeons, vascular surgeons, even in other specialties. So people really were greatly panicked. Well, I remember when we were in the month of March and April. I think the panic was much more, and we really did not know how to deal with this situation. A lot of the professionals, they just closed themselves up and stayed like that for weeks together, and before they finally opened up and came back into their practice and all those things. So the situation is pretty much escalating. Till now, more than 24 million people have been infected worldwide. More than 830, the count today is exactly more than 8,30,000 lives have been lost. A vast majority of them in Europe and the Americas, including United States of America and Brazil, Mexico. In India, also more than 60,000 lives have been lost. So it has been really terrible and something that we haven't encountered in our lifetime. This is situation in Bangladesh, more than 300,000 cases now, more than 4,000 deaths. And we have been having a rate of diagnosis at 20 to 25% of the tests being performed, which is coming down. I don't know. I mean, that is one trend that defies my understanding, that we have been doing 10 to 50,000 tests nowadays routinely. We reached up to 18,000, I remember, but I don't know what is the logic behind coming down. So that gives us an idea that, or keeps us in a state of confusion. I mean, where are we actually? I mean, we really do not know, because the mortality has remained where it used to be. So can we call it an improvement, or it is deteriorating? So there is no official way to say where we are really heading. So the doctors, I mean, the community of doctors in Bangladesh have really suffered very badly from COVID-19. I mean, I know that more than 4,000 doctors have been infected to this point, more than 100 casualties, more than 110, I guess now. And the case fatality rates among doctors have been pretty high. I mean, this is one of the highest, I guess, in the world. I mean, Italy, India, these are the countries where the doctors suffered. But in Bangladesh, the fatality rate has been around 3%. So every day we are getting news of a doctor dying here and there in the country. So that really is a source of panic being spread among the doctors. But I think the doctors have done a tremendously good job defying the panic and the mental burden, and getting themselves dedicated to these services they are expected to do. Among the vascular surgeons, to my knowledge, there have been 4 infections. I can say that. I mean, in our vascular society registry, we have 35 to 36 registered vascular surgeons in the country. Out of them, 4 had COVID infection. Fortunately, all of them recovered without any major debilities or sufferings. So the modus operandi, I mean, worldwide, I mean, the vascular surgeons, like all other specialties, those are providing care, they have proposed guidelines during the working guidelines in COVID-19 pandemic that is quite different from what we are used to do in ordinary times. So emergency has been the focus of operations. I mean, we have to see that no emergency is not is left unattended, but we have postponed the routine issues until the situation improves. So that has been just be a point when we will be required to be getting back to the new normal situation. There has been suggestions, so there has been guidelines or recommendations as to how the vascular surgeons should operate during the COVID-19 pandemic. And like I said, mostly the arterial cases, especially those with the chronic limb-threatening ischemias, they cannot be ignored, but mostly all other things can be postponed for a certain period of time. Of course, I know there are penalties to be paid, but the recommendations has been such that the limb-threatening ischemias be treated, or all other issues are deferred as much as possible. This is something that came out from the American College of Surgeons. I mean, basically the same thing. They went into a further detail of addressing the major diseases, including aneurysms and all those things, and they had their recommendations like do not postpone, consider postponing, things like that. In Europe, worldwide, there has been a committee that was formed to see the effect of the deferral that has been going on. I mean, how our patients are paying the penalty. So there has been a committee who have been who are required to input, give data regarding these sort of deferrals and how their patients have been impacted by this deferral. So it's a committee now having more than 300 members coming from 28 countries. Turkish Vascular Society, they had their own proposals and they operated during the COVID-19 pandemic in their way. The same came from Portugal as well. So coming back to Bangladesh, so we also thought of doing something similar and doing something or setting something up in a formatted manner. I mean, like everybody else in the world, we thought that, well, we are a different country. We have a different, resources limitations, things, I mean, that do not apply to many other countries. We have a limited number of vascular surgeons. We deal with a large population, and our emergency case burden is probably larger than many other countries. So given all these realities, I think we needed to have our own guidelines. I mean, that can be proposed for our population, taking into account the resources and the population that is to be dealt with. So this is what we came up with, actually, and I told you that this is what I exactly wrote in that article that is going to be published now. I mean, this is a little bit more detailed than what we have worldwide now. I think I set up these recommendations that there are procedures, there will be procedures that we must do, cannot ignore. There are procedures that, I mean, these are a little bit of changed recommendations. I know there will be procedures that we must do, things that we should not defer. There are things that we can consider deferral. There can be things we should defer, and there will be situations where we can consider aggressive medical management instead of all the interventions we would otherwise plan. So these are, I mean, disease specific, something we do when some acute limb ischemia situation comes. There is a detailed description of the conditions here, and a recommendation has been set for this particular group of patients. The same applies to the vascular injury. I mean, probably acute limb ischemia and vascular injury with all their attending circumstances, they fall into the category of must do or something like that. We have CLI that are claudicants, probably we can think of deferral, but things that have tissue losses, severe rest pains, those are the patients that are deserving. And we have other issues like the arteriovenous fistula issues. I'll tell you that you will see that dialysis access patients who actually were needed to be served during this COVID-19 pandemic. So these are disease-specific recommendations that I proposed, of course, and I adapted this thing to the realities of Bangladesh, and I proposed this to be applied for the Bangladeshi population and for the Bangladeshi working vascular surgeons. So in the venous disease also come up into these considerations. So I'm not going into all the details here. So that is a formatted set of recommendations that I wrote and I included in that article I wrote, and this is going to be published in the Annals of Vascular Surgery. So what we did, I mean, the major source of service, as you understand, is the emergency vascular department of the vascular surgery department of NICVD. That's where a congestion pandemic. We, of course, kept the OPD open. But although it was a bit limited, but of course we kept everything open. Duplex was done. Of course, the numbers came down, but the services was open, and we actually set up a roster-based activity that was mostly supported by the junior vascular surgeons and was guided by actually closed for the past 3 or 4 months, and now it has come back to normal. I will mention it a little bit. Vascular scenario that will be long remembered, and intention that we keep these things in mind when we get over the pandemic. Looking back on it will be easy when we have photographs like this. Okay, these are the kind of attire, these are the kind of situation we used to have during this difficult for us to help remember, reflecting on. Actually, we did more than 200 emergency vascular procedures at NICVD. Most of them actually are vascular repairs, required vascular repairs. We had HD access complication issues that came in significant numbers. We did not do any venous procedures over the last 4 or 5 months. We tried to exclude COVID-19 infection whenever possible before doing procedures on these patients. We tried to defer the suspected COVID cases whenever that could be done. And whenever we knew that this is a COVID, non-COVID patient, we tried to address these patients in other ways other than committing ourselves to surgery. Outcome for an ICVD, well, the first thing is that the services continued. I think that is very important to mention, that the services remained active throughout this period, and no patient was actually turned away without giving service. One thing is that limb loss for critical limb ischemia was a bit higher when compared to the pre-COVID period. I think the number was like about 73 to 75% limb salvage rate. That used to be more than 80% in non-COVID period. So you can understand that the limb loss was a bit higher. As regards the infection among the vascular doctors, I think at NICU, 2 of our colleagues became COVID positive, and they recovered uneventfully. I mean, to make things better, I think the private center also came up to work and to provide service during this time also. Of course, not all the centers were equally active. Some worked to their capacity, some worked to the 60-70% of the capacity, things like that. Unfortunately, most of the centers are based in Dhaka, like you know, and that is one thing that is not really very helpful to cover this large population. So everybody needs to come to Dhaka to avail a vascular care. So that is something that is not really good for this population, and that affects the limb salvage very much. Like it has been discussed, when we have to amputate something, it is not a good feeling for any of us. But if we consider the reality, all these patients need to come to Dhaka from remote areas, and they take time. By the time they reach us, the limbs, or certain part of the limbs, are in a state of non-salvageable situation. So I think these are the main reasons why we lose a lot of limbs. And when there was lockdown, the issue of reaching Dhaka became all the more difficult, making limb salvage prospects more and more slim. So is the access, creation, and care from the main bulk of the patients. When you talk about the private centers, I remember I, along with my team, had to commit ourselves to creation and care of HD access in a significantly increased numbers in COVID-19 pandemic. We did not do any procedures, not me. Maybe there's some. He was, and that was supplemented by the many centers by telemedicine service. Taken so more than a couple of hundred procedures. If we aggregate the number that operate the last 4 months, we did more than. That's not a very bad number. And like we practiced at NICVD, we tried to exclude COVID-19 infection. All the cases we known COVID, we did not do any known COVID case, and suspected cases were deferred as much as possible. Outcome, like I said, amputation needed. We did the care so many patients, even during this time of COVID-19 pandemic and the lockdown situation, so many patients, even neck injuries and all those things. I mean, uh, this sort of injuries kept coming in. So these are the critical limb ischemia cases we had to take up. Access creation and care, the access, puncture-related problems of the hemodialysis access care. We did the fistulobram, fistuloplasties in a routine manner during the COVID-19 pandemic, because these are all the also the patients who needed to be dialyzed. Not really say no to this patient, so we continued this sort of care during the COVID-19. Numbers, well, these are the numbers actually in ICVD cases and my private cases taken together. So these are the numbers. I think over the last 4 months, I guess more than 350 cases we did in different categories. The results are here. These are the data I presented in another article. I think that is in the pipeline, I guess, should be published in another international journal maybe. So these are the results. Like I said, the successes just mentioned. So that's pretty much the end of it, basically. And I just want to mention about the academic activities that we continue during the COVID-19 pandemic. I understand that the different societies, Bangladesh Cardiac Society, IPDI, BIT, even the Indian Vascular Associations, all those platforms, they did tremendous job in continuing the academic exercises during the COVID-19 pandemic. I mean, over the web, online-based things. And we lagged behind a little bit on the Vascular Society to begin with. But it's a good news that recently we have got started with the academic activities, and Mughal sir also took class for the students. I also spoke on a couple of occasions, and I have also contributed and participated in many of these online academic activities. So a bit late, but into it, and we would like to continue this academic endeavor during this rest of the period. So what is the new normal? Like you said, we have been back into the new normal situation. At NICVD, we have started the routine procedures. We did CAT today, where some routine cases were addressed. Our ward is now open. The routine patients are being admitted. More than a dozen procedures has already been done over the last couple of weeks. So it's pretty much the new normal for us. I don't know what the shape of this new normal is going to be in the coming weeks or months. I think the COVID-19 situation will dictate a lot of these things. I think one thing, the quick tests, I mean, one thing that really come to affect the decision making for the vascular surgeons, the availability of quick tests. I think that changes a lot of strategies for the cases that come into us. So I think we hope that these quick tests will be available in the coming weeks or months. So before I end, I would like to give another good news, and that is we, the vascular, I know the cardiologists do it. We, the vascular surgeons, did our first carotid stenting at NICVD today. And it's a good case, as you can see the images here. There's a tight stenosis in distal common carotid, and we put a prestige stent here, and the outcome was pretty good, I think, in the end. So that is the end of it. Actually, I'd like to pay my tribute, my respect for the physicians, teachers, of COVID-19 pandemic. May Almighty Allah bless them with a place in the heavens. And I once again thank Afzal sir, Dr. Mohsin, and all others in the BIT platform for giving me this opportunity. Thank you very much.
Thank you, Dr. Hassan. Also, I think all the vascular surgeons, they are doing tremendous job during pandemic era. Thank you, Dr. H M Bashar. Abdul sir, Abdul sir.
Can we?
Yeah. Sure, sir. Please give me a second, sir. Okay. I think, sorry, how to do that? Yeah.
Okay. Yeah.
From here.
Thank you.
So, actually, now thank you all. It is just I will give the thank you to everybody. That John is left because he has to go to the camp, and I think so. Sir also not there. Thank you, Mukbul, for your making time because you were very busy, and also the Bashar. Now you are taking all the load, all the load in NICVD. That is to tackle because I know that NICVD. I think so. Many of the patient is coming up, and now the floor is patient is on the floor now. Again, the same scenario is coming in NICVD. And thank you also the Kaisar. Now Kaisar is coming. He is the immediate past secretary general of the society, but he is a very dynamic. He's not only interventional cardiologist, he's a versatile cardiologist. He used to do the pacemaker, he used to do the nowadays he's also doing the peripheral. So I must congratulate you. So God give him more energy, more courage, and long life, I think so. And Habibur Rahman, same to you also. You are doing diversity of the cases, I know. And also the
Dr. Habib, just a comment on the chat box. BIT can job to all the sectors that is John, how to develop the peripheral intervention, peripheral people. Without revascularization, I think podology is the most important part for limb salvage, that is amputation. How we works? Dr. Afzal said comments regarding this. How we prevent the amputation? How do podology develop podology in Bangladesh?
So the main thing is that awareness of the people is most important,
Yes,
and
sir.
the collaboration awareness is very important because we have to ventilate the message to 180 million population that you can save your life by doing the vascular intervention or vascular surgery, and you have to detect the case earlier. And there is some test I have seen because I have to come to this session. I have seen that there is some knee test. There is some test for the knee joint to how we can evaluate a test like that. So many simple tips is there. So we can ventilate this news not only among the surgeon but also among the physician and the general surgeon also. And we have to be collaborated between the other discipline also, like general surgeon, like vascular medicine specialist. That's most important. And then integrated work. And we need more dedicated manpower for this intervention actually. And definitely there is a financial constraint, but definitely we can give the support from the other sources also, and we have to work for that.
The most important, for the younger people, need the more, I think, job satisfaction, more post in the government medical college. They're posting and promotion everything for the vascular surgeon or vascular cardiologist. Recently, there is 50-bed hospital in all the divisional in Bangladesh. H cardiac center is going on recently. You sir, you know everything because you are doing last 2 years doing this project. I think so. But I think yes, sir. But I think one thing is there is cardiology, cardiac surgeons, pediatric cardiology, and pediatric surgeons. But there is no vascular surgery there. There is no post-patient is there. So I think vascular surgeon should be come forward. There is lots of post is there in the 8 divisional. I also see the last 2 days working with this, but there is no vascular surgery post or there is no vascular surgery bed in this project. Sir, I think if you comment, sir.
No, actually, I know this project because this project is started from the that is our previous honorable minister, that's Nasim sir. এই সময় প্রজেক্টটা শুরু হয় প্রত্যেকটা ডিভিশনাল শহর ডিস্ট্রিক্ট শহরে it is the project vision of the Honorable Prime Minister. Actually, this is not the vision of anybody. This is the vision of the Honorable Prime Minister that বাংলাদেশের সব জায়গাতে প্রত্যেকটা ডিসিপ্লিন এক জায়গা হতে হবে, লাইক nephrology, like gastroenterology, like that cardiac surgery, like this main discipline is there. So I think so it is not a big deal, because government is not prepared the full plan. That is the time you should contact with the vascular surgeon, and you can create a post is not a problem, because I have get the opportunity to work with the for sanction the post of the NICBD. It is not a difficult job. Just you have to be satisfied the bucket. You have to be logically put the thing that everything will be solved, because everybody has soft corner to the cardiology and cardiac surgery and vascular surgery. Everybody, money is not a problem, and government is very positive. So
but 2 days back in the meeting, I was studies that there is no post in the vascular surgery. There is no bed in the vascular in this. So vascular surgeon Dr. Bashar and Mugul, you should go to the ministry, because it is the most important. There is no vascular surgery department in the division. It is the medical emergency for every person, not only the vascular surgeon. Everybody needs the save the limbs and medical accidental injury and everything. But these projects, there is no vascular surgery post also vascular bed. I think so. Abdul sir is also help in this regard. I think so.
That we can do. Society can work. Then individual can work. That's not a problem. Problem is that there is a less number of the vascular people. If we create a post, how we can fill up the post? That's the problem. Because in a project, if there is a project, if the post is there, if there is nobody is there posted there, then the post will be abolished. That is also limitation. You know that we have a project in the different medical colleges. At the time, nobody is gone there. So every professor post was abolished. That's the problem. So definitely, but that post can be reserved by giving the posting of the other doctors. We can handle that tactfully, no problem. I think the Bashar, Mukbul, along with the NICBD director and the Mohsin can go there. But if you need my help, I'm ready for that.
Thank you.
You always push the young people to come forward to the vascular surgery department. Also, I think congenital heart disease, PKMC, valvular heart disease. Last 2 years in your directorship, we are everybody. Kaisar bhai?
Kaisar.
Yeah. First of all, definitely, BIT has made a platform global. Is like TCT, like TCT AP South Korea, TCT MD USA, and Sing Life, and also in our neighboring country India through BIT. And I must say, sir has taken a big vision to collaborate all the cardiology sectors together, like coronaries are doing everybody, and chiefs, the complex coronary cases, then peripheral. Today he's done this case. Then also he has done the. I must grateful to him for one reason, that he has done a course even for nurse and technicians. I think he has done 2 or 3 courses, certified courses. He's brought some person from outside who's very, very good teacher. I performed that course for the nurse and teacher, because it's a teamwork. I must thank Professor Abdul Rahman sir and BIT, and I thank it from my heart. I'm not the person to, what is what, I always tell that. I don't appreciate a person without any reason. So definitely, I must thank from all of our behalf. I must thank our vascular surgeons as well. Mukbul bhai, Dr. Bashar, they have done a wonderful job. Especially, they are doing very, very complex cases now. And Mukbul bhai, in the beginning, when vascular surgeons peeped into the intervention, Mukbul bhai used to do cases with me. Not now. I'm talking about 8 to 10 years back. I think the Mukbul bhai remember those days to do together cases, CQ cases, peripheral CQs. Lots of. Then Mukbul bhai forgot me, so I also forgot peripheral. Now Habib bhai is the person who stimulated me. One day Habib bhai came and said that I think this year in the beginning, February. He told me that I'm going to a program in Delhi, you should go. It's a very good peripheral course. And then we went together, we had a very nice time. So my point is that we need a good collaboration between the vascular surgeon, between the intervention cardiologist, and another sector not developed in our country that is called intervention radiologist. So they also do peripheral cases. And in my hospital, my friend is Dr. Jan Mohammed, who is a very good radiologist. I encourage him to come to my lab and do it. Because, you know, after, one thing I've just gone through a book which is called Die Empty. So before your death, you give whatever you can, because you can't take in your grave those things. You do knowledge, you experience, and that will live in others' hand if you give this thing. এটা মানে আমাদের মুসলিম ধর্মের সাদকায়ে জারিয়া, আপনি যে কাজটা করে যাবেন সেই কাজটা যদি অন্যরা শেখে জুনিয়ররা, তারা যখন তাদের মাধ্যমে অনেকগুলো লোক উপকার পাবে, তখন ওই উপকারের সওয়াবটা আপনিও পাবেন। হ্যাঁ, এটা সাদকায়ে জারিয়া আমাদের ইসলাম ধর্মে বলে। আর এর বাইরে তো মানে সবাই বলে in respect of religion that this thing will leave the legacy in the whole world before you go away, like Mother Teresa has left his legacy. So আমার কাছে মনে হয় যে three or four fields still you need to work out. One is peripheral, one is structural heart disease, among them, you know, SD, DSD closure, TAVI, and mitral valve clipping, LA closures, and third thing is EP. These three sectors we should work. Coronary has gone to a standard now. Coronary, there's 90% of the works are done in Bangladesh, what we do in the whole world. But peripheral, EP, and structural heart disease, we are lagging far behind, especially peripheral. So vascular surgeon, intervention cardiologist, and even if radiologist comes, because I need the radiologist when I'll go for tough cases like, you know, kidney operations, like taking the AAA, taking the aortic sections. Then we need to do the CAT scan and need to visualize things properly. And for that reason, I think every sector can give their inputs, and especially surgeons can take the post care also, like the which Bashar, Dr. Bashar told and Mohammed told that, you know, the care of the wound and these things. And we should do more seminars. But unfortunately, juniors are not interested about EP, about peripheral, about structural heart disease. Maybe it is tough. Maybe the economic
earning
gains are less. But I tell always to my juniors, if you know something extra than coronary, it's a feather to your cap. So you know coronary, you know cycling, but if you can do driving, it's an extra feather to your cap. So if you know peripheral, if you know structural, if you know EP, it's good. It's good.
Thank you, Professor.
I think we should have more collaboration with vascular surgeon and intervention cardiologist, and also the radiologist as well. Thanks.
Dr. J M bhai. Dr. J M
Abdul Sir যেটা বলছিলেন যে স্যার অ্যাওয়ারনেস among the patients, before that awareness among the doctors are needed primarily. স্যার বুকে ব্যথা হলে হার্টে ডাক্তার সবাই সার্চ করে, কিন্তু যখন হাতে ব্যথা পায়ে ব্যথা ভাস্কুলার আসতে অনেক দেরি স্যার। কেন? হাতে ব্যথা পায়ের ব্যথা দেয়ার আর সো মেনি কজেস, অ্যানালজেসিক, এইটা সেটা, তারপরে তেল মালিশ, অনেক কিছু, এভরিথিং। সেখানে অর্থোপেডিক সার্জন আছে, সেখানে রিউমাটোলজিস্ট আছে, সেখানে ফিজিক্যাল মেডিসিন আছে। কেউ একবার পালসে হাত দিল না, নো ওয়ান ফিলস দ্য পালস, হোয়াট ইজ দ্য কন্ডিশন অফ দ্য পালস। When there is gangrene or there is tissue loss or there is ulcer, then search for that. So by this time, times are already lapsed. So awareness among the doctors, vascular surgery knowledge, medical colleges যেটুকু আমাদের knowledge ওইটুক দিয়ে, কারণ বাদ
মেইনলি তোমার কোলাবোরেশন করতে হবে, বুঝছো? যেটাই বললাম, ইন্টারনেস্ট, তারপরে নিউরোলজিস্ট, তারপরে অর্থোপেডিক, এদের সাথে তোমার কোলাবোরেশন করতে হবে। ওদের অ্যাওয়ারনেস আছে, ইউ হ্যাভ টু কোলাবোরেট ইচ আদার, ইউ হ্যাভ টু মেক অ্যান ইন্টারলিঙ্ক কানেকশন ইচ আদার। কারণ ওই ইন্টারনেস্টেরও কিন্তু অ্যাওয়ারনেস আছে তোমার, কিন্তু কোলাবোরেশনটাই হলো ইম্পর্টেন্ট। লাইক ওদের যে ফোরামগুলো আছে, সেই ফোরামে তোমাদের যেতে হবে, ফোরামে তোমাদের বলতে হবে, বিকজ ইউ আর দ্য লিডার। ভাস্কুলার সার্জারি তোমরাই তো লিডার, আমরা তো লিডার না, ইউ আর দ্য
রাইট স্যার। আমরা
অ্যাওয়ারনেস এন্ড দ্য কোলাবোরেশন, অ্যাওয়ারনেস এন্ড দ্য কোলাবোরেশন দুইটাই হইতে হবে।
জি স্যার, আমরা সুযোগ পেলেই ওদের ফোরামে কিন্তু প্রেজেন্টেশন কখনো মিস করি না, সেটা নেফ্রোলজি হোক, ইউরোলজি হোক, অর্থোপেডিক্স, জেনারেল সার্জারি, সব জায়গাতেই কিন্তু আমরা আমাদের প্রেজেন্টেশন গুলো।
আরেকটা জিনিস বলছি যে পোস্ট গ্রাজুয়েশনের জন্য দেখো গভর্নমেন্টের কোনো পোস্ট নাই, কিন্তু গভর্নমেন্ট কিন্তু এই যে ভাস্কুলার সার্জারি ইম্পর্টেন্ট বলে অর্থোপেডিকে দিচ্ছে, চিটা কাজেই কিন্তু বাসার মুভ করে হেড অফ দ্য ডিপার্টমেন্টকে নিয়ে, এনআইসিউ ডাইরেক্টরকে নিয়ে, তাহলে ইজিলি কিন্তু পোস্ট ক্রিয়েট করতে পারে বাসার।
স্যার একটু স্যার বুঝলাম স্যার, ওগুলো থেকে কি জন্য দিচ্ছি, এটা কি স্যার মানে ভাস্কুলার সার্জারিকে স্যার মানে ভালো করার জন্য না না এটাকে আর আন্ডারমাইন করার জন্য? আমি এটা ক্লারিফাই করি। আমি
না, ভিশন হলো কি যে ডিসেন্ট্রালাইজ করার জন্য।
দিস ইজ রং স্যার, দিস ইজ রং। কারণ একটা লোক যখন ডেভেলপ করছে কষ্ট করে, সে ভাস্কুলার সার্জারি থেকে ইন্টারভেনশন শিখছে স্যার এই বয়সে, বুড়া বয়সে, ওগুলো মাইন্ড করে না, বুড়া বললাম, আমি বুড়া, হ্যাঁ। তারপরে যখন ডক্টর বাশারও আসছে স্যার, এদেরকে স্যার সেন্টারে রাখতে হবে এবং রেখে এদের মাধ্যমে।
বিষয়টা হলো কি, তোমার ট্রান্সফারের ধরনটা ঠিক হয়নি, এটা তুমি বলতে পারো, কিন্তু পলিসিটা ঠিক আছে যে চিটাগাংয়ে একজন ভাস্কুলার সার্জন দিতে হবে, অর্থোপেডিক ভাস্কুলার সার্জন দিতে হবে, ঢাকা মেডিকেল ভাস্কুলার সার্জন দিতে হবে, এটাকে ডিনাই করার কিছু নাই। মকবুলকে এনআইসিবির দরকার ছিল, মকবুলকে এনআইসিবি নিডি, সেটা আগেও বলেছি আমরা, এখনো বলছি, ভবিষ্যতে বলবো, ঠিক আছে। এখন পোস্টিং তো সবসময় হলো কি, পোস্টিং তো আর নট ডান বাই দ্য অ্যাডমিনিস্ট্রেটর। যাই হোক, এটা হলো অন্য হিসাব।
যখন দেশের স্বার্থ থেকে বড় হয়ে যায় স্যার, তখনই আগাতে পারে না স্যার। আপনাকে আমি আপনার সাথে তর্ক করবো না স্যার, আমি তো খুব স্পষ্টবাদী স্যার, ইট ইজ রং স্যার। আপনার প্রোগ্রামে আমি ঝামেলা করতে গেলে স্যার, ইট ইজ রং।
এটা ঠিক আছে স্যার, রিগার্ডিং পোস্ট ক্রিয়েশন কাউকে না কাউকে উদ্যোগ নিলে এটা হবে। যে কথা বলছিলাম স্যার, সারা বাংলাদেশে যত জায়গাতে মাল্টিডিসিপ্লিনারি হসপিটাল আছে, দ্যাট ইজ এ ফার্টাইল ল্যান্ড ফর এ ভাস্কুলার সার্জন। কেন? ভাস্কুলার সার্জনের কাছে মাল্টিডিসিপ্লিনারি থেকে পেশেন্ট আসে, অর্থোপেডিক্স থেকে, জেনারেল সার্জারি থেকে, ডার্মাটোলজি থেকে, নেফ্রোলজি থেকে, লট অফ পেশেন্টস ইন দা হোয়ার দেয়ার ইজ এ মাল্টিডিসিপ্লিনারি হসপিটাল, দেয়ার ইজ এ ফার্টাইল ল্যান্ড ফর এ ভাস্কুলার সার্জন। নাম্বার 1। নাম্বার 2 স্যার, ডক্টর বাশার প্রেসিডেন্টের যে কেস স্যার এনআইসিভিটিতে এই প্যান্ডেমিক সময় ইনিশিয়ালি যখন সবাই তটস্থ, তখন কারণ সবাই দূর থেকে পেশেন্ট দেখছে, কিন্তু ভাস্কুলার সার্জনরা কিন্তু ইমার্জেন্সি কেস রিফিউজ না করে পেশেন্টের কাছে যে অপারেশন করছে, এটা স্যালুট দেয়ার, থ্যাংক দ্য এভরিথিং দে ডিজায়ার্ড।
থ্যাংক ইউ
স্যার। বাট এট দ্য এন্ড অফ দ্য ডে এখন যে সিনারিওটা তৈরি হচ্ছে, যে এখন টুয়ার্ডস নর্মালিটি, এখন যে আমাদের যে পলিসি মেকিং কে, এই ধরা যাক ক্যাথল্যাব প্রসিডিওর অথবা ওপেন সার্জারি প্রসিডিওর, আমাদের স্টিল আমরা বিভিন্ন জায়গাতে যেটা হচ্ছে যে কোভিড টেস্ট করার পরে পেশেন্টকে ক্যাথল্যাবে বা ওটিতে ইন করানো হচ্ছে। বাট কেউ যদি সত্যি সত্যি কোভিড পজিটিভ থাকে আর তার যদি কোনো রুটিন বা ইমার্জেন্সি প্রসিডিওর করার দরকার হয়, তখন সেই স্টেপ বা প্রিকশন আমরা কি এটাকে একদম ডিফার করে দেব, না এটাকে নিব, না কিভাবে? যেমন ভাইরাস পজিটিভ হলে দেয়ার ইজ এ সেট প্রোটোকল at the end of the day, last case, etc. But when there is a COVID positive, then emergency case, what is the protocol? Or কারণ আমাদের তো এরকম সেপারেট ডেডিকেটেড না ক্যাথ ল্যাব আছে না ওটি আছে, আমরা এই জায়গাতে কিন্তু এখনো থেমে আছি। কিন্তু যদি কোনো কারো কোনো সে থাকে তাহলে এই অডিয়েন্স
না, দ্যাট ইজ নট রাইট, দ্যাট ইজ নট রাইট। তোমার যেটা রিসোর্স আছে সেটাকে মোবিলাইজ করতে হবে, আর লাইফ সেভিং প্রসিডিওর কোভিড পজিটিভ হলেও করতে হবে, এ ব্যাপারে কোনো সন্দেহ নেই। করোনার ক্ষেত্রে কিন্তু সাপোজ এনআইসিবিডি দোতলায় ক্যাথল্যাব, একতলায় ক্যাথল্যাব, সো ইজিলি ইউ ক্যান নাও ডাইভার্ট ইট, যে আমরা কোনটা কোভিড পজিটিভ করবো, কোন জায়গায় কোভিড, ইউ ক্যান মেক ইট লাইক দ্যাট, দ্যাটস নট এ প্রবলেম, ইউ হ্যাভ টু সিট টুগেদার, দ্যাট ইজ আপ টু ইউ। আচ্ছা, যাই হোক, এটা হলো ব্যাপার। আর যেমন ইউনাইটেড তারা এখন করে ফেলছে, তারা কিন্তু করছে, ল্যাব এইডও করছে, অনেক জায়গায় করছে। আমি জানি না যে ইবনে সিনার খবর কি, ইবনে সিনা তো এক জায়গায় মনে হয় ক্যাথল্যাব, ইবনে সিনা ক্যান ডু দ্যাট। সো আমার মনে হয় যা রিসোর্স আছে সেই একটু ইঞ্জিনিয়ারিং করলে, একটু মেকানিজম করলে অনেক জায়গায় কোভিড পজিটিভ টেস্ট করতে পারবে। আর কোভিড টেস্ট কিন্তু অনেক জায়গায় সকালে দিলে 3টার মধ্যে হয়ে যায়, কোভিড টেস্ট কিন্তু একদিন লাগে না, বিকজ আই হ্যাভ ডান মাই কোভিড টেস্ট ইন ইউনাইটেড টুয়াইস or thrice for traveling outside, so I give the COVID test in the morning at 7-8 a.m. and I have got the report at 3. Even যদি আমি না চাই, হার্ড কপি না চাই, তারা 2টার পরে দিয়ে দিতে পারে। তার মানে কোভিড টেস্টে 24 ঘন্টা লাগে, দ্যাট ইজ নট ট্রু, দ্যাট ইজ নট ট্রু।
স্যার আমি একটু বলি স্যার, এই কথাটা একটু টেক দিস, সেটা হলো কি আমাদেরকে কোভিডকে নিয়ে বাঁচতে হবে। এটা কিন্তু আগামী আমার মনে হয় না বছরখানেক আগে যাবে, ভ্যাকসিন হবে, এটাকে প্রমাণ করতে হবে। সো 1 বছর আগে মনে হয় এটা যাবে। সো সব জায়গাতে, সব দেশেই এখন কোভিডকে নিয়ে বাঁচার একটা অ্যাডাপ্টিভিটি ডেভেলপ করতেছে। তো যেখানে যখন মাল্টিপল ক্যাথল্যাব আছে, ইগনিশনের 2টা ক্যাথল্যাব আছে, আমাদের যেমন 3টা ক্যাথল্যাব, হার্ট ফুশনে 8টা ক্যাথল্যাব, বার্ডেমো মানে 2টা ক্যাথল্যাব, সেখানে একটা ক্যাথল্যাবকে আমরা ডেজিগনেট করতে পারি কোভিড এবং সেখানে আমরা করোনারি পেরিফেরাল সব ওখানে করবো আর একটা তো নর্মাল কেস করবো।
কিন্তু এন্ট্রি এক্সিট আলাদা হবে, এন্ট্রি এন্ড এক্সিট আলাদা হতে হবে। দুইটা ক্যাথল্যাবে এন্ট্রি এন্ড এক্সিট আলাদা থাকতে হবে। সেটা ইবনিসিনা নাই, সেটা ইবনিসিনা নাই যে এন্ট্রি এন্ড এক্সিট।
না, তোমার ইবনিসিনা নাই, তোমার ল্যাবে আছে, ল্যাবে আছে,
এনএসবি আছে, এনএসবি সম্ভব, এনএসবি সম্ভব।
What about ICU? ICU তো সিঙ্গেল ICU।
What the vascular surgery or cath lab?
না, cath lab
or
CCU। ওটা সেপারেট। CCU তো একই কম্পার্টমেন্টে সব পেশেন্ট রাখা হয়, তাহলে ওখানে কি আলাদা ফ্যাসিলিটি এটা কিভাবে? হাউ
should be other?
না,
আমরা যেটা করেছি, আমরা এখন আলাদা একটা রুম করেছি এবং মানে যদি আপনি অফিসিয়ালি করতে চান এটা কিন্তু সোজা না, রুম আলাদা করলে হবে না, আপনাকে এসি ভেন্ট সিস্টেমকে আলাদা করতে হবে। যেমন আমরা একই ফ্লোর ছিল সিসিউ আর এইচসিউ, মানে পোস্ট সিসিউ বলতে পারেন আপনি যেটা বলেন না কেন। তো ওই পোস্ট সিসিউকে আমরা এখন কোভিড সিসিউ করতেছি আর সিসিউকে সিসিউ রাখছি। এখন সেটা করতে গিয়ে তো আলাদা রুম করা হয়েছে এবং ওটার ভেন্ট সিস্টেম আলাদা করেছি আমরা, এবং ওখানে নেগেটিভ প্রেশার রাখতে হবে। এগুলো না করলে আলটিমেটলি এয়ারবোর্ন ডিজিজ অ্যারোসল প্রডিউসিং হলে এটা বেশি মাত্র ছড়িয়ে আট থেকে ছড়িয়ে যাবে। তো আইডিয়ালি আপনি যেটা বললেন মুকুল ভাই, একই সিসিউতে আপনি দুটো রাখতে পারেন না, এটা পসিবল না। আপনাকে আলাদা ফ্লোর করতে হবে বা আলাদা একটা ছোট রুম নিয়ে, আপনি বিছানায় ধরেন 5 তলা একটা রুম আছে, ওখানে আপনি একটা 6টা বেড বা 8টা বেড দিলেন। প্রথম কথা হলো কোভিড কেস তো আমরা করি না। আমরা কোভিড যদি কার্ডিয়াক কেস হয়, যদি সেটা খুব ইমার্জেন্সি না হয়, লাইফ সেভিং না হয়, আপনাদের ক্ষেত্রে হতে পারে অ্যাকুট ইসকেমিয়া, এরকম কেস হতে পারে। সিটিও যদি করবেন না কোভিড, যদি সিটিও কোভিড হয় বা মানে অতকম মানে টিপিক্যাল না হয়, তাহলে আপনি বলবেন কি তোমরা ওষুধ খাও, 14 দিন পরে কোভিড টেস্ট করো, কোভিড টেস্ট নেগেটিভ হলে আইসো, তখন আমি করে দেবো। অ্যাকিউট ইসকেমিয়া হলে, কোর লিম হলে বা আমাদের ক্ষেত্রে যেমন মানে এমআই যেটা ওষুধের কাজ করতেছে না, আমরা প্রথমে চাই স্টেপিকাইনেস দিয়ে টেনেটিভেস দিয়ে কন্ট্রোল করতে, তখন আমরা বাধ্য হয়ে লাইফ সেভিং হিসেবে এই করোনারি স্টেটিং করি। আদারওয়াইজ কোভিড কেস আমরা অলওয়েজ চেষ্টা করে দেখবো।
না, আমার মনে হয় যে প্রাইভেট হসপিটাল করাটা খুব ইজি, গভর্নমেন্ট হসপিটাল ইট টেকস টাইম, কিন্তু চাইলেই মনে পারা যায়। আমার মনে হয় বাসার নেক্সট ইওর স্টেপ শুড বি দা টু ক্রিয়েশন অফ দ্য পোস্ট ফর দ্য ভাস্কুলার সার্জন। ইনশাআল্লাহ তোমার হেড অফ দ্য ডিপার্টমেন্টকে নিয়ে, এনআইসিউ ডাইরেক্টরকে নিয়ে তোমরা যাও।
স্যার আমাদের একটা জুনিয়র কলিগ স্যার একটা চ্যাটের মধ্যে লিখছে, দেখলাম তার কমেন্ট আর কি, ডক্টর সজল, ওরা বলছে যে স্যার লট অফ ভাস্কুলার ইয়াং ভাস্কুলার সার্জনস আর কামিং আপ এন্ড দে আর ওয়েটিং ফর। দেখলাম
যে যদি প্রেসক্রিপশন না হয়, যদি ভালো জায়গা না হয়, তাহলে জুনিয়র ইয়াংরা আসবে না। এই জন্য বলছি আমরা শুড বি আমাদের
কোভিড তো মানে আই এম এ ভেরি গুড নেগোশিয়েটর, এটাই বলতে পারি।
আপনাকে কাজে লাগানোর স্যার খুবই দরকার।
আমি নেগোশিয়েট করতে পারবো, মানে তুমি যখন নেগোশিয়েট করতে দাও, আই ক্যান ডু দ্যাট।
স্যার আপনাকেই লাগবে স্যার ইনশাআল্লাহ।
তবে আমাদের শেষ দিকে চলে আসছি স্যার, আমরা অনেক সময় হয়ে গেছে স্যার।
না, থ্যাংক ইউ,
থ্যাঙ্কস এভরিবডি, বাট উই শুড প্রোটেক্ট আওয়ার হেলথ প্রফেশনালস ফার্স্ট। Bashar, our colleagues, our nurse sister. Yesterday I just read a chat, one person, he was admitted in BSS hospital. He is the cardiologist, pediatrician, MD pediatrics, Dr. Shoaib. He is and his wife admitted in BSS, a serious condition in Shamoli Special Hospital. He wrote, we just suffered from COVID-19, spend lots of money, but government not support us. So we seek support from the government. So what we do from the juniors? What we doing from our health professionals? Nobody helps the juniors. Nobody helps the COVID survivors. So we should protect ourselves first, our profession first. So thanks everybody. Thanks Beximco Pharma and also their participants. Dr. Afzal Rahman sir, please conclude the session.
No, thank you everybody. Thank you Maqbul, thank you Bashar, thank you Habibur Rahman, and thank you Kaiser and also the Mohsin and George Slep, and thank you all the participants.